I think I'm standing between you and break, right? So that's always an ominous spot. Let's see if I can find my slides. And so I'm reminded of a quote by FDR who said, when you're standing between people and food, you should be brief, you should be sincere, and then you should be seated. And so I'm gonna try to at least be those three. My name's Joe Smith. I'm a cardiologist, cardiac electrophysiologist, so I'm a geeky, really uber geeky cardiologist. I started off life as an uber geeky engineer, so I live in the space between technology and healthcare. And listening to the three ominous talks before me, just fabulous presentations, I was reminded of a quote by Oliver Hazard Perry, who was in a naval battle in Lake Erie, which I think separates the U.S. from Canada. And it's like 201 years ago next week, he said, "I've met the enemy and he is ours." In 1971, Pogo, a comic strip, paraphrased that and said, "We've met the enemy and he is us." And as a doc standing before you, faced with your revelation in this fabulous meeting about healthcare, I'm impressed with the notion that we meaning me representing doctordom and healthcare, we are the problem in many ways. And so I feel like I'm in an AA meeting, right? When the first part of any 12-step program is acknowledging the problem. And so I desperately want to acknowledge the problem. Thanks for that. Let's see if I can move us along. So I want to talk about these three things, really. The healthcare cost problem we have in the United States. Not in any deference or reference to Canada, but we do have a unique healthcare cost problem here. How this notion of interoperability, and I know that's an 8-syllable word, but I think you all innately get it, and I'm going to try to take you through that, because what that means as we think about a connected, coordinated kind of healthcare world that replaces the chaotic conundrum that we have at the moment, and then why I think that's moving, give you some evidence to believe that we might actually be making some progress. And so not to tell you that the healthcare problem is merely a cost problem, but we have an important, terribly important healthcare problem, and that relates to cost. And so, numbers really don't tell a story very well, but it turns out that cost is best described in numbers. And so we're at about 18% of GDP in the United States. That's way more than anybody else spends, and GDP is kind of a concept difficult for everybody to get their arms around. What it means is that, like, for most families, the money available to them would be about 10% higher if we were just doing what OECD countries were doing, or that healthcare is really spending 20% of their money before they get it, is another way of thinking about it. And it's not getting any better. It's not spontaneously healing, right? So it has gone from unsustainable a decade ago to persistently unsustainable now to persistently unsustainable in the future, and the numbers are getting worse. And so the notion that there's some divine intercession that's going to make our healthcare spending somehow manageable, that doesn't appear to be occurring. And so as we as a population age, as our innovation engines spur out, wonderful new therapies, like, I don't know if you saw that you can now have your hepatitis C cured for $84,000, or you can have your Gaucher's disease treated for nearly $300,000 a year. We are getting better at solving some problems, but in a way that is economically borrowing money from our grandchildren in a way which is really kind of irresponsible and completely unsustainable. Even our current president has recognized that it is in every way unsustainable. And so here, I think you can get this, right? So healthcare spending has been growing faster than the rest of the economy for 4 decades. Right? So every year, the amount of money we spend proportionally more on healthcare. We spend so much on healthcare that we had to crimp our defense budget. And so we're becoming, in every way, a healthcare economy, right? So if you can imagine, anything that grows faster than the rest of the economy over time will eventually become the economy. And so, here you've got our president saying, by 2025, all we can pay for with our current tax dollars are healthcare programs, Social Security, and the interest we owe on the debt. Everything else, we're going to have to borrow money for. And you can pretend we're borrowing from the Chinese, or you can pretend we're borrowing from each other. We're ultimately borrowing from our children's future. And so I would encourage you to think about whether the healthcare product we are getting today is worth putting your children and grandchildren in debt for. And then if not, then get busy trying to help us solve this. Before we lost our last Secretary of Health and Human Services, she said, we are living sicker and dying quicker. And so you've got, notably the most responsible person for healthcare in the country talking about the notion that we're not doing so good while we're spending so much. And so, I like the CIA fact book. I think they're charged with getting things right. Our infant mortality rate is 56th in the world, right? That's not so great. Our US life expectancy is 42nd. That's not so good, particularly when we outspend every other country on the planet, most by more than a factor of 2. And so, you could take a spinning globe, throw a dart at it, and be much more likely to hit a higher value healthcare system than ours. This I found pretty interesting. I mean, for those of you who are thinking to living till 2029, the notion that good mathematical models based on how fast our economy is growing, how fast the family of 4 is growing in their income, how fast healthcare spending is growing, changes the way we pay for health insurance plans, because it's more high deductible healthcare plans, we're having more out-of-pocket expenses. These authors found that by 2029, the average family of 4 would take 100% of its take-home pay and spend it on healthcare premiums and out-of-pocket healthcare expenses. Well, clearly we're not going to get there, right? I mean, because at that point, you wouldn't need to spend any money on healthcare because you'd be starving to death, right? So we're not going to get here, but the point is the trend isn't getting better on its own, and either we work to solve that, or at some point between now and then, we're going to get a solution rendered from on high. There's going to be a substantial orchestrated change by people who are charged with helping us with this problem. And so figure out who you like better to solve your health care. You want to solve it with innovation and with all sorts of nice ideas to kind of get the cost down? Or do you want our federal government to make changes to the way doctors are paid or hospitals are paid or what kind of health care you can receive? Those are the challenges in front of you. This is my organization, West Health. It's privately, philanthropically funded by 2 very nice billionaires who remain relatively quiet, have no vices and no children, and looked around and said, hey, what can we do with our legacy to try to make a difference that's going to be meaningful for the United States? And they said, what we should do is we should collect some smart people and see if we can't do something to make healthcare cheaper in this country. And so what we've done is created 4 organizations, really, a medical research organization, a policy center in DC, an investment fund, because it turns out no matter how smart you are and no matter where you work, most smart people still work somewhere else. Right? There is no way that you get most smart people working with you. And so that we have an investment fund to make sure that we can propel other people's rockets as they try to get things done. And then a small business incubator. If we think there's a good idea that will really pull costs out of the healthcare system, we'll try to propel it that way. And so what we try to do is pioneer new and smarter technologies, policies, and practices. And technology leads in wordage, but it's clearly not the case that there's going to be a gifted gadget that is going to save healthcare. There is no app that saves healthcare. There is no EMR that saves healthcare. There is no wonderful implanted stent. I've implanted those. There is no wonderful implanted pacemaker. I've built those and implanted those. None of those things saves healthcare. They may save individual patients, but we have a structural problem. And so let me talk a minute about interoperability, because we are here at a great meeting in a great place in Silicon Valley where a lot of really cool technology is being built to try to help people manage healthcare issues that are of real import. If you think about where 75% of healthcare dollars are spent, we've had this over the last 2 days, this notion of, well, it's 5% of Americans that consume 50% of the costs, or it's 10% that consumes 2/3. Really, when you think about where healthcare dollars go, they go in the management of chronic disease, right? So chronic disease and its complications, that's 98% of Medicaid dollars, that's 75% of Medicare dollars. It's a lot of the money we spend is on chronic diseases. And as we as a population age, guess what? That's not getting better. Chronic diseases accumulate as you get older. And so this issue is getting substantially worse. And where do those people show up to be costly? Largely, they show up to be costly in emergency rooms, hospitals, doctors' offices. When you think about the critical care of patients who have decompensated chronic disease in hospitals, you have to realize that when you show up in a hospital, you are surrounded by a bunch of gadgets. Those gadgets actually don't ever talk to each other and rarely talk to the electronic medical records and never talk to the cool little gadgets that you have at home. So if you're a patient struggling with diabetes and you've got 4 devices that surround you at home, the notion that they all talk to each other doesn't exist. And the notion that your doctor can integrate with all those, or when you go to the hospital, that they can download that information and work on it, doesn't exist. And so the opportunity for that to occur as a way of knowing you better, taking care of you better, integrating up that information, understanding you so we can keep you out of the god-awful circumstance of decompensated chronic disease is still open. Only a third of hospitals integrate any medical devices with EHRs, and then for the most part, it's a small number of the devices that do exist. When we took a look at this, if there's almost $3 trillion spent on healthcare, $750 billion is wasted. We took a look at what fraction could be pulled out if we took this circumstance, which is actually one of our own employees' fathers, is dying in the middle of this sea of medical technology, all of which is individually safe and effective, but collectively a chaotic mass of hot mess is what it really winds up being. And so we took a look and said, hey, if you put these all together, if you let these smart devices talk, right? So a theme of this meeting is coordinated care. You heard a presentation this morning about Stanford doing care coordination. Well, that's the notion of getting professionals to share information and work in a team. If we can't start that, let's at least start the notion that their gadgets will talk. Let's make sure that the information flows smoothly, because it's got to be at least 80% of healthcare is information management. And so getting the information to flow seems like a real opportunity. When we looked at how much you could save, it looks like you can save about $36 billion a year, pull that out of the healthcare system. But it's not just the money. It's the notion that the bedside nurses, and I'll tell you, as a doc, I have to sign up to all the commentary that was offered earlier, that the empathy of modern healthcare is largely being eroded or missing in places. But I married a nurse practitioner, so I understand where empathy is actually delivered. The bedside nurse has this wonderful opportunity to largely protect the patient from the well-intended in a hospital who can create more harm than good at times. But they are distracted by the medical technology that they are managing. We have an internet to manage all of our cool technology at home and when we're traveling. In the hospital, we use SneakerNet, right? We ask the nurses to kind of move the data from one smart device to another smart device. And so, you've got a critically ill patient, you've just intubated them, they're on 3 different drips, and you got to change their vent settings, and there's information about all of the ways all of those things should be happening, and it's all having to move through the nurse, or the doc, or the care team. But none of it's moving seamlessly and smoothly. And so, the opportunity to kind of decrease the cost of thinking of the professionals by having that information flow seamlessly saves time, saves money, and saves lives. And so we're pushing on it. When we talk about it, you can look at it either as a glass half full, glass half empty notion. There are lots of limitations imposed by the fact that none of these smart devices actually share any information. But the way we look at it, there's a tremendous opportunity that relates to savings in cost and in time by letting the internet that has changed everything change the practice of very complex healthcare in the most expensive settings. And so I'll tell you that this 8-syllable word is gaining some momentum. The Institute of Medicine, which is typically where Congress is supposed to turn for its insights as to what medicine needs, they've clearly pointed out that interoperability is required. ECRI, which does a great job of pointing to hazards from technology, points out that it's really interoperability failures are responsible for, I think at this point, 6 of the top 10 leading concerns of medical technology. Amy and the FDA speak about misaligned incentives for the companies who develop these technologies to actually have them be interoperable. We put a meeting together in February this year, and the audience response demonstrated that everyone seems to believe that the reason we don't have interoperable EMRs for the moment is that the EMR vendors choose not to create it that way because it impacts on their business model in an unfavorable fashion. Because once you land in a place, you can expand if you have proprietary information sharing strategies, as opposed to a more generalized approach. We spun off a thing called the Center for Medical Interoperability. It's a standalone 501c3 where we're putting the boards. The board of that organization is made of the CEOs and CMOs and CIOs of the hospital systems that are buying equipment, and we're getting them to turn to the vendors and say, I love all that cool stuff you're doing, but I'm only going to buy it if it talks to all the other cool stuff I'm buying. Otherwise, go pound sand. And so that's the notion of not necessarily using government regulation to drive this to an answer, but using the market to drive this to an answer. After we did that, and we had the current national coordinator at our meeting. She subsequently came out with her 10-year plan for getting our country on an interoperability axis within what seems like an eternity of 10 years. And then in June, we got the FDA to announce that it's doing its best with recognizing standards and actually having it will issue draft guidance in how manufacturers can actually claim that their devices are in fact interoperable. And then just in July and August, we had both Energy and Commerce and Senate Finance weigh in with their interest on helping to create a more interoperable healthcare ecosystem. And so at this point, I kind of want to leave it a little bit to you, because this doesn't happen all by itself. There isn't a single vendor who says, oh yeah, I want to change the way my stuff works so it can work with everybody else's, because in fact, they experience a benefit, So, God, I used to work at J&J and Boston Scientific, and I completely understand the value of having a proprietary information strategy. And I think I worked with folks at Philips who said, we love interoperability, and as soon as people make their stuff work with ours, we're all good. I don't think that's the right way to handle the problem. I think we need the same sort of interoperability that we each have when we tweet during this meeting, right? It doesn't matter whether your phone was made by Samsung or Apple, whether you're running Android or iOS. It all works together because we've got an internet protocol which has been standardized and is open. And we need the same sort of communication in healthcare. And so I think the time is now. The Greeks had two words for time. Right? They had chronos, which was the typical passage of time, and kairos, this notion of a moment of supreme relevance. And I think we have that now in healthcare. We have reached a point where it is functionally, logistically, economically unsustainable, and I think this is one of the things we need. It's not going to solve everything, but it's essential, because if you want to talk about big data, integrating up big data to make big inferences about how to manage diseases, you've got to bring that data together. You can't when it's in silos that don't talk. And so you need to liquefy the data and make it so that it flows wherever it's needed best, and you won't get there if everybody's talking about it in a different way. We've got an unprecedented increased access. We still don't have 100% insured like we do in Canada, but we're much closer. And so we've added new folks to a healthcare system which is already strained beyond its breaking point. This seems like one of the tools we need in the near term. And so I'd ask you, when you think about this, patients are waiting. This data, we need to have this form of coordination and cooperation of our technology so that we can do it with our people as well. And so thanks a bunch. If I can answer any questions, I'm happy to.
I was wondering if you have any insight on VA system, because at VHA, when I see a patient, I already have access. If I actually want to, I actually can pull data from how he was treated when he was at the Department of Defense. I have this information, but obviously they have their own problems as well. I was wondering, from your consultant side, is there any connection or communication between the two systems? Because there's something that infrastructure at the VA that's could be generalizable. No, I think the VA has done a great job. I mean, I used to work in VAs during my training in Boston, and it has gone from a kind of a scary place to practice to a great place to practice, and that the VA EMR systems are remarkably good. But I think we still haven't, while we've licked the EMR problem, we haven't licked the medical device problem. You still have, an infusion pump that's trying to control someone's blood pressure, and the infusion pump is blinded to what the blood pressure is. That would be like having you drive your car without ever having a speedometer or windows. You wouldn't really do that. And so we need to make sure that the technology is informed with the endpoints it's trying to reach. Otherwise, you burden the nurses with the notion of making sure that all of these things are working collectively together. And that's just
it's too much to ask at that point. And as our information and our technology grows seemingly exponentially, we've already eclipsed the bandwidth of most of the folks who are at the bedside.
So I just so you can see me, sorry. Rita Sharon at Columbia Medicine talks a lot in her narrative medicine program about this idea that as we bend over the work, our heads touch. And it's got me thinking a lot about this whole digital technology thing that, if we have iPads, they seem to be separating, and we have this issue of empathy. You alluded to that earlier. But it's interesting because when I think of an iPad, I think of us bending over the work and our heads touching over it, when we see a chart or a patient sees a chart. And I hadn't thought this until you're talking, but I wonder if one of the issues of interoperability is we aren't looking at interoperability from the perspective of we all bend over the work and our heads touch. It's all in one screen, in one place. It's all talking together, accessible by the patient, accessible by any clinician, always in one. We're looking at it in the ICU, a very specific nurse in a very specific situation, very specific machines, and emerge very, very context specific. We don't think about it generally. And I'm curious what your thoughts are on that.
Yeah, so having my background in technology, technology development and medical technology approval in this country does not contemplate the collaborative. It contemplates the individual. And I don't mean the individual patient, I mean the individual device. And so it's even a challenge for our regulators here at the FDA to imagine the approval of a device whose interaction with other devices changes the way it works. And so imagine that that's the case, that everything has to, in order to get to the market, has to be completely self-contained, and then you thrust a whole bunch of them together and ask them to work well together. It's piece-wise but pound-foolish. Nothing else? Please.
I'm just curious as to what you would say when whatever other company you consulted with, J&J, if somebody came to you in your previous role, how would you respond to what you're asking for now?
It's one of the reasons why I wound up leaving J&J was that the big incumbents are kind of at war with their customer at the moment, right? Because you have a fiduciary responsibility running a big company to shareholders, right? And so that's top line growth, it's economic performance. And the notion that our healthcare system is already struggling under expenses which it can no longer afford puts you in Dutch, right? I mean, how do you want to grow at the price of the sustainability of the enterprise in which you're living? That's not so great. And so it's going to be the startup, it's going to be the independent, it's going to be in some ways the nonprofit who's going to have to disrupt this enough. Big companies are always challenged with disruptive innovation. It's just not, it doesn't live well within a big infrastructure. And so I do think, a lot of the incumbents are going to struggle during the revolution in healthcare that we desperately need. And it's it's places like this where you get, the passions here, an understanding of the problems here, some of the technological capabilities here, and then let's just go. And, I think some of the large incumbents will have their Kodak moment when they go, oh my gosh, guess what? This film thing, it isn't working anymore.
I'm disruptive.
Excellent.
I'm the disruptive person you're talking about. I started a nonprofit to help people understand how to understand the medical device that's being presented to them by the manufacturers, specifically Johnson & Johnson, since you mentioned them, and Boston Scientific with polypropylene mesh. And you may be aware of the
absolutely
federal litigation in that regard. And my question for you is, since you seem to have walked on both sides of the fence and, in my opinion, ultimately chose your good superhero power, your superhero power to use it for good.
I think there shouldn't be two sides of the fence. I've heard that described here in other earlier parts, like on one side versus the other.
Yeah, it shouldn't be, but it is.
Yeah.
So reality is just, whether we believe it's true or not, it still is. The question I have for you is, we've talked about all of these ECR applications that different hospitals and practices use, and the fear of technology that physicians have, or any position within a physician's office. I generally just try to think of what will help, and then I just try to make it happen. And so the constituency of my nonprofit is baby boomer generation, primarily women, who we talked about are now having chronic illness, which is the most expensive user of the healthcare system, and is also wiping out the families that these women used to manage. And so I thought, well, wouldn't it just be easier, because have gone to so many different doctors with my mom. There have been no long-term studies on the specific device I'm speaking of, and so nobody knows what's going to happen. So we had to go to 12 different physicians, and the 12 different physicians don't talk to one another either. Not just the technology, but how do I make the pelvic pain specialist talk to the neurologist? How do I make the neurologist talk to the her primary care physician? And they seem to not be interested in discussing the patient as a whole at all. And so I thought, hey, I'm going to make a USB bracelet for my mom and put all of her medical records on it so that she doesn't have to, as a very sick woman, go in and fill out 97 forms and tell the front desk the same thing that she's going to have to tell the nurse again in 15 minutes, that she's going to have to tell the doctor again in an hour, that she's going to that they already have, because this isn't her first appointment. So here's a USB bracelet, plug it in to whatever ECR you use, and here is the patient's medical history. I've experimented on this. Some doctors are like, oh, that's awesome, hand it to me, and can I keep it? Yeah, you can keep it. Or no, it's my mom's, but you can, everybody knows how to use a USB. Other doctors are like, oh, like they're afraid it's going to break their computer, like Camille said, or they're afraid they're going to break some hospital rule or something. And so after all that explanation, I'd like to be more disruptive. Uh-huh. Can you help me know how to be more disruptive in that way?
Yeah. That's an enormous question. I don't think I can in a meaningful way from up here. But I'd say a couple things. I think pointing to the problem's important, and as you've done, identifying a potential solution is terribly important. But I was talking to somebody earlier, and this notion of piece solutions, I think we wind up with the second level of problem. A lot of the solutions that we engender are narrow enough that by adopting them you create other issues. And so this notion of how best to get all your doctors talking and confronting them with information, I'll tell one little vignette. And so as the chief medical officer of a medical device company that was making implanted devices that were smart, we figured out a way to make sure that those devices could, if ever they detected there was something wrong with the patient or with the device, they could immediately move information and present that to the implanting physician. And so we thought that was great. I rolled that out to our medical advisory board, and they said, let me understand what this does. When the patient gets sick or if the device has a problem, it sends information to my email address at that moment. I said, absolutely right. And they said, that's great. If you put that in your devices, we will use your competitors' devices. Because you create for me unmanageable liability, and at the same time, you present me with information that I normally get another way, which is billable, and your way isn't. So what you've done is you've enhanced my liability, you've decreased my reimbursement, you've changed my quality of life. I'm not up for that. And so that is a rational response from those providers, but it is not about the patient. And so our innovation was incomplete. It was a great idea, but incomplete. So we needed to manage it so that that information wouldn't land in someone's unopened email box in the middle of a Saturday evening, but that it would go to someone who was in a position to respond and was compensated to do so. We needed to work with Medicare to make sure that when that information moved, it actually had some economic incentive for the care system to look at it. And then it worked great. And so some of the things that look like wonderful solutions aren't, because they've not worked in the flow of both the economics and the workflow of all of the care providers. Oh, it's one more thing, right? So I'll just tell you, my first day as a doc in the emergency room of a metropolitan Boston hospital, when they put two patients in the emergency room and one has a thick chart and one has a thin chart, we run to the room with the thin chart. right? Because frankly, more information is more time, more complexity. No, that, in terms of the way, yeah, more data, but data isn't always good. Data is sometimes a tremendous investment. And so the number of innovators who've come to us on the investment side and said, I get this great app that'll move a tremendous amount of data to the doctor, it's like, that's great, except the docs don't want a tremendous amount of data. They want refined information that's an unassailable cue for action. But they do not want to be besieged by PDF after PDF of everyone else's misinterpretations of some set of facts.
Well, as a patient advocate, I know enough about what the doctors that handle my need. They need post-operative reports. There are specific things that I know that physician. So I load the bracelets with that. I know that they need.
Yeah, that's great.
But I guess my larger question is, we've been kind of preached to, you need to be part of your solution, your healthcare solution. Well, I'm trying to be, but you won't let me.
Yeah.
So how you're putting me in a catch-22. Pretty sick.
Yeah.
And I can't figure this out.
Yeah. No.
I don't have a job to figure it out. In fact, I'm paying you.
No, and I think, and not to belabor the point, but I do think that a lot of the material that goes by, a lot of the data is so rich that it is beyond the bandwidth of, at times, the care providers, and most often the patients who are struggling. And that's where I think there needs to be some automaticity and coordination of the technologies that surround folks, as opposed to asking them to do all of the cost of thinking and then the cost of communication. I think some of that has to be assisted.